Today's kind of a day of hopefully learning from the experience of other states. That's how we've kind of put the program together. I'm going to be kind of northwesterny and not too formal in terms of introductions, but I at least want to mention names, and in turn we'll get to know them a little bit better. First of all, we have Rick, who is right here and has some experience over the years, particularly from the state of Arizona, where he was very involved as that state moved its system into managed care, the long-term service side of things. Deborah and Angela are both from Michigan, and we'll talk about the experience in Michigan. And third state that we have visiting with us, Camille and Lynn, who are right here from Wisconsin. So we'll talk about the Wisconsin experience. In addition, we have asked Chris Emhoff. Chris, where are you? Chris. And Nathan Johnson from the Healthcare Authority to share experiences that they have within our state working with managed care in some other arenas other than the DD arena. So with that, I think we'll just kick off, and we've asked Rick to kind of start the program this morning. And Rick, do you want to use the podium or the mic?
Thank you, Ed. David, I appreciate that. I'm trying to figure out why I got to go first, and David initially suggested it was because Arizona is alphabetically first, and that I probably am used to it. In fact, my name is Zaharia, and I'm used to being at the end, so it can't be that. The other possibility is that when we talked with Deborah about their presentations, my talk with you this morning is going to be at a pretty high level, pretty descriptive, nuts and bolts about managed long-term service and support systems. They're going to get a little bit more into the human side of what those systems can generate in the way of good services for folks with developmental disabilities. With that, I need to probably give you a disclaimer and a little bit more history. I was state director in Arizona for 6 years, and I ran one of their regions for 5 years. I retired several years ago, and I'm doing private consulting now. So I'm not an official state representative. You can't hold the state of Arizona accountable for anything I talk today, and I'm not responsible for any problems that ensue from this. I'm an observer and quite frankly, a fan of the system. Before coming to Arizona, I was the state director of the Division of Services for People with Disabilities in Utah. Did that for 5 or 6 years. And it's a pretty traditional state in terms of fee-for-service health plans, a pretty traditional HCBS waiver state. So when I came to Arizona in 2000, I approached managed care with a lot of trepidation and a lot of anxiety and a lot of concern about, was this really good for people with disabilities? And I got to tell you that after 10 years in that system, I liked the way Arizona did managed long-term service supports for people with developmental disabilities. I don't know that I'm a fan of managed care or that whole business, but I'm a fan of the way Arizona did it, and I'll try to articulate that as we go through this. First of all, if we could, let's start with a definition of what is managed care. I've lost my screen up here, David. This one here. A definition of managed care, and there probably are a number of them. It's a set of strategies intended to control the costs of services and to impact the quality of care, hopefully for the better. Those strategies typically involve capitation, risk sharing, prior authorization, utilization review, and quality management. Why is everybody interested in managed care all of a sudden? It's not all of a sudden. If you've been in the field for the last 10, 15 years, it's kind of come in waves and gone back into healthcare and then come back in waves, and it's here again, I think probably and most likely because of the recession, the tight times that we've been in, and states looking for ways to find cost efficiencies in their systems. And managed long-term services and supports can provide some budget predictability, which is what legislators like, what policymakers like. It can provide increased access to services, and it uses extensive data upon which better utilization decisions can be made. It emphasizes front-end and preventative services and permits the integration of care across settings. Those cost savings come from the bundling of acute care services, and in Arizona, behavioral health services and long-term services for people with intellectual and developmental disabilities under a single administering agency, allowing for efficiencies across those services. Care coordination and case management can integrate supports across systems. I was talking with a friend of mine about the experience he's recently had with the Mayo Clinic and how they coordinated services across specialties and disciplines. That efficiency not only is less costly, but it usually results in better outcomes. Services can be provided early and in the home before things get very expensive. And capitation pressures continuously emphasize cost containment throughout the system. What are some of the strategies used by Managed Long-Term Service and Supports Program? I've already mentioned a few of these. Some of them, like preventative services, case management, quality management, are not unique to Managed Long-Term Service and Supports. They're just heavily emphasized in those programs. Digging in a little bit, prospective capitation. That's where a managed care entity agrees in advance to a fixed payment per individual served. When I left the state of Arizona, we were capitated at $3,500 per member per month, no matter how many individuals we served. And at that time, we were serving about 25,000 individuals across the state of Arizona in the managed care program. Care coordination. Care coordination is the organization of activities between two or more providers in order to facilitate efficient and appropriate care. What's most obvious is, and I was continuously awed by our system's ability to make sure that people move from home to the hospital, to convalescent or step-down care, and then back home in a smooth, integrated, positive way for the individual in that situation. And it doesn't always happen that way, but we consistently were able to make those moves, and I think gain some efficiencies as a result of care coordination across acute care systems and the long-term care systems. Utilization review, developing decision rules based on post hoc review of usage data. An example of this for you is the state of Arizona has been paying family members of adult children for in-home attending care for a number of years. We went back and started looking at the data and realized that we were paying many of the family members more than 40 hours a week, and confronted the fact through our lawyers and whatnot that we were probably violating Department of Labor rules, but we were also probably burning out families and family members. So we instituted a maximum number of hours on individuals. The family could have another aunt or sister do the care, but they were also maxed at 40, and you could bring in a private provider to do more if more was needed. But through that rule, we were able to institute something I think that probably impacted care positively and made sure we didn't have Department of Labor problems. Prior authorization, everybody's familiar with that. That's getting or giving approval in advance of services or supports. Whenever I have to get a cornea transplant, my doctor has to call the insurance company and get approval before they'll proceed with the operation. Limitations on freedom of choice as a strategy. Typically, you have a limitation on the number of providers in the system, in the network. You qualify them, you certify them. You have limits on leaving a provider, moving to a different provider, and limits on choosing expensive options. For example, in Arizona, with our state, we're an 1115 demonstration waiver. The ICFMR, the ICF-IDD entitlement to those services is waived under the 1115 waiver. It's our most expensive option, and it made no sense for that to be outside of the cost equation. Families, substitute decision makers can't choose an ICFMR unless our processes, our pre-approval processes deem that as necessary. Risk sharing, managed care entities typically will agree to absorb the losses and keep the profits from that capitation rate that I described to you above. And over the 10 years, we lost money and we made money. And this betrays to you a bias that I'll talk a little bit more in a few minutes, that I'm not totally comfortable with the idea that a managed care for-profit entity is going to be taking those profits and not reinvesting them in the company. I've seen what it does on the behavioral health side in Arizona, where in fact that is the case. They contract with behavioral health entities, companies, big companies, national companies, to run services in large parts of the state. And the one in Maricopa County in Phoenix, the largest in the state, they're on their third MCO, their third managed care entity in 10 years, at least the 10 years that I've been there. And performance is a problem. Those profits are a problem. When we were losing money, our department would absorb the losses, help us figure out how to deal with coming in short of our capitation. If we made money, the department kept that funding and allowed us to reinvest it. They reinvested some of it elsewhere too. But it stayed within the human services sector and did not go to pay salaries and other kinds of things that I'm sure happen in the private sector. Okay, so to Arizona specifically, according to the National Association of State DD Directors, Arizona was one of the first states to have attempted to comprehensively serve all eligible individuals with developmental disabilities through the managed long-term service and supports model. In fact, I don't know if it's sexist or not, but they call themselves the granddaddy of managed long-term service and supports. According to David Braddock's national data, Arizona's IDD program is the 8th cheapest program in the country. We serve the 6th most folks with developmental disabilities per 100,000 population based on, again, his 2011 data. And that's through an entitlement program, which I'll get to in a minute. According to the United Cerebral Palsy's annual report for 2012, Arizona was ranked number 1 in the annual assessment report that they do called Case for Inclusion. And it's been ranked number 1 for the last 5 years on the domains of keeping families together, living in the community, providing home-based services, and so forth. Now, Washington, by the way, was ranked number 8 in that report, and that's nothing to sneeze at. Okay, a little bit of history. Arizona was one of the last states in the country to take Medicaid dollars from the federal government. We're very proud of that. The cabinet-level agency created to run Medicaid was called AHCCCS, the Arizona Healthcare Cost Containment System. In 1982, HCFA, or CMS today, approved an 1115 Research and Demonstration Waiver that permitted Arizona to experiment with a prepaid capitated acute care program for Medicaid recipients. This is the longest-running 1115 demonstration waiver program in the country. It's still demonstrating after all these years, and we're quite proud of that. In 1988, an 1115 waiver revision was approved to add long-term services, ALTCS. The same managed care principles were used as an acute care, the ones I mentioned earlier. And I think this is about the time that Sue Elliott was in Arizona And she is a legend, by the way. She and Brian Lensink basically built the foundation for our community-based system. So you've had one of our legends here. Again, use the same strategies that I mentioned earlier in terms of managed care principles applied to long-term care services. And I think at that time it was the first to apply those principles system-wide. Arizona's system is an entitlement system. If you qualify as IDD, which includes an access-administered adaptive assessment, which is supposed to predict risk of institutionalization, you're in the program, and the Division of Developmental Disabilities has to serve you, and the legislature has pretty consistently funded the growth projections annually that we make on that program. The attractiveness of this to legislators is that it is predictable. You pretty much know what your costs are going to be based on your ability to project growth. And in Arizona, that can be tricky because we were a high growth state. So the legislature, in fact, has pretty consistently funded those growth projections. In fact, in Braddock's last State of the States, Arizona was one of 25 states that grew in real dollars in IDD services over the 2009-2011 recession years. Now, that's not to say that Arizona didn't strip out unmatched state dollars, that we squeezed services, we reduced rates, and we tightened up eligibility process, but the total dollars were still increased over this period to serve large numbers of people. There is no waiting list in Arizona except for spot shortages for specific services. So the entitlement has worked for Arizona. The way it's organized in Arizona, and I'm going to be interested to hear how the other states are organized. Access, ALTCS is the payer, the quality manager for the system. They hold the contract with CMS. They in turn contract with the Arizona Division of DD, which probably looks, I worked with Linda over the last decade, and I think the two divisions look a lot alike. But they have a contract with Access. The Division of DD, in turn, contracts with 4 or 5 health plans throughout the state to provide acute care. At that time, when I left, we were paying about $430 per member per month to the health plans for the health care for our individuals, which was, I think, $1 less than they were paying for the non-disabled Medicaid population, which we were kind of proud of. In turn, we also have a contract with the State Behavioral Services Division, with whom we contract to provide behavioral health supports. So for each individual that we have enrolled, we pay the State Behavioral Health Division $100, at least at that time, $100 per person per month, regardless of whether they use the service. A nice arrangement, brings its own problems, but it solves a lot of the issues about who's responsible for this individual or that individual. We basically bought their services. Below that, the state division manages through 5 district offices and about 50 local offices through both support coordination and care coordination to the 25,000 members that we have statewide. And it's below this point where the system looks probably identical to Washington's and most other states. We contract then with a network of day program providers, residential providers, in-home providers, the whole continuum, and their paid rates probably very similar to they are in Washington. So for the consumer, for the family member, the managed care system is invisible at that point because it's not part of their lives. In 2009, Bob Gettings, who is former director of the State DD Association, described 4 states with managed long-term services support systems focused on people with intellectual and developmental disabilities. Those states were Arizona, Michigan, Vermont, and Wisconsin, and you have 3 of the 4 here today, so you have those of us with the most experience here. Truven Health Analytics in 2012 reported that the number of states managing their IDD programs through the Managed Long-Term Service and Supports model had doubled to 8 states, including Washington. But in that case, Washington's Medicaid Integrated Partnership Program, I think it's a one-county, Snohomish County behavioral health program, serves folks with IDD who are not in the waiver, who are not in ICFMRs. So it's a little bit different animal than I think the rest of us have. I do have problems with the Truven report. This is one of the tables out of their report, and Vermont has had the program called Global Commitment for managed care of in its system, long-term service and supports, and yet Truven neglected to mention them as one of the 8, so that if you included Vermont, it would also be on this list. And Deborah was saying that one of the dates were wrong for Wisconsin, so Truven may have, for Michigan, 1998. Okay. You have a summary of this, but the President's Committee for People with Intellectual Disabilities reported in their 2012 report that the number of states implementing the managed long-term service supports models for our folks was going to increase to 26 states by 2014, 2015. So it's on the horizon for everybody. Is it inevitable? I don't know, but some of the advantages that you can consider as you go forward with your planning is that it does allow for improved access in return for capitation. That is, there is the possibility of more people being served through a managed long-term service and support systems. It is consistent with our values in developmental disabilities of preventative, community-based services before costly crisis and institutional services. And it can be flexible within bundled services. We did some really fun things, some really creative things with supported living as part of that capitation. It does simplify the system for users in that there are not multiple waivers or programs with which they must deal. In fact, as I said before, the managed long-term service system is probably invisible to a family or an individual receiving services in Arizona, and they wouldn't even know necessarily unless they were told that it was a managed long-term service support system. Care coordination between acute and long-term care systems does result, I am convinced of this, and someday I'm going to prove it, in what may be better mortality and morbidity rates. Part of my repertoire is having done mortality research over the years, including examining all the deaths of all the individuals who left the California DC system and went into the community. At one time, there was research suggesting they were dying at rapid rates. We did the research that said maybe not so much. It can't be any more life-threatening to live in the community than in the institutions. And in fact, that research has been reaffirmed over the years. And in fact, I think Washington does one of the better jobs of watching mortality rates. But what happened in Arizona during the 2000s is that the mortality rates among that 25,000 group of people dropped to one that was close to that of the general population. And if you know anything about mortality rates in developmental disabilities, that is really extraordinary. More research is needed to verify that, but I think a systematic application of some research on those things, perhaps with a paired state, would show the positive impacts that a managed long-term system of supports has on those two outcomes. There is an emphasis on provider networks, which means there may be more choice of providers and more geographic availability. It is a problem to be in Yuma, Arizona, and to only have one day program provider. And the managed long-term support system basically says that is a problem that needs to be fixed and needs to be dealt with by the managed care entity. The system is driven to serve members early when costs are most likely to be lowest. I'm particularly proud of our ABA early intervention system for Medicaid-eligible toddlers in that we were spending, by the time we left, by the time I retired, we were spending several $1 million putting that intervention into homes of these young children and beginning to show, we were watching the cohort of young children. We began those programs in the 2005, 2006 years, and we were beginning to show some positive outcomes from that early investment of ABA in the home that hopefully sustains itself during the school years. But because we were in a managed long-term services system, it made sense to invest a lot of money in those youngsters. And it wasn't a heavy lift at all for us to build that program that way. It allows service plans to be designed based on individual needs rather than programs for which people might be eligible. All of which is to say that you may be facing some managed care going forward. But there are some disadvantages, and we need to be candid about it, and I hope my co-presenters will get into these too. It can eliminate provider scarcity or a lack of provider creativity. If you are having problems with PTs, speech therapists, OTs, managed long-term services and support systems will not solve that problem for you. If you have providers who can't get out of their day programs and move into supported employment, it's not going to help you with those problems. Federal oversight constrains access, I think, more than in most states, which in turn constrains DDD. And I know from Utah, and I know from other states and other involvements, that everybody has federal oversight. But because of their particular interest in managed long-term service and supports, they seem particularly interested in what's going on in Arizona and this 30-year demonstration waiver, and that goes downhill. We felt a lot of the federal involvement. We thought it was intrusive in some cases. Capped administrative rates can limit IT, personnel, and infrastructure expenditures. During most of my period in heading up that division, we were limited to about a 4 or 5% overhead. In other words, of that $3,500, we could only pull down 4 or 5% for the central office, for the rate setting, for the negotiators, and so on, which is good news in that, that was always positively received by our legislators. But on the negative side, when we had something like the HIPAA compliance issues come through the system in the early 2000s and had to build HIPAA compliant budgeting and billing and case management systems, it became a major issue that we could not, in our system, you do not go to the legislature and ask for more money. We only deal with access, although legislators are interested in our budget. We negotiate with access on that capitation rate only. There is no, we need 20 more cars and we need 10 more staff, and the legislature funds those. We have to negotiate those into that capitation rate. So that can be a problem. Managed long-term services and supports is a complex system with many moving parts, so it is challenging to administer. I had dark hair when I started in Arizona, right, Harold? Higher cost services are more difficult to get approved during tight times, which may not be unique to managed care systems. Sustainability in Arizona over the long haul has been questioned, even though those per person costs in adjusted dollars in Arizona, as I mentioned earlier, were 8th lowest in the country. And finally, managed long-term services and supports don't fix the problems of conflict of interest. They don't fix the problem of direct care salaries, and they don't fix the problem of dental services. Suggestions, which I guess are the main takeaway for today's panel in terms of what we're going to leave with you. The National Council on Disability and the National Senior Citizens Law Center have generated principles and toolkits and guidances for states that are thinking about going into managed long-term services and supports, and I commend those to you. They've done a lot of good work. CMS, the Center for Medicaid and Medicare Services, established a managed long-term service and supports office and website, which has recently issued guidance on managed long-term service and support systems. My personal suggestions after having lived managed long-term service and supports for a decade include: it does have to be uniquely shaped to your system. I can imagine managed long-term service supports working real well in Utah, where the system is a mirror image of Arizona with state employee case managers, state offices. But it would be a real challenge in a state like California and Colorado, where I've worked, and they have very strong local regional center systems. You do have to build in core values from the get-go. It is a constant battle working with managed long-term services against medicalization. It is doctors and it is nurses who are wonderful people, but they're the ones who manage the managed long-term service support system for access. They're the ones they rely on for reviewing plans of care. They're the ones that staff the access bureaucracy, and they're constantly having to be educated and re-educated. I don't know if the other states have this problem, about how the medical model doesn't fit always in a social service model. We'll take the best we can get from you, but what you're suggesting won't work. And every time there's turnover at access, we have to go back over and re-educate. And you just have to be in that mode where you'd rather fight the battle up front rather than downstream when you're in the middle of a notice to cure or a plan of corrections. Vigilance is important. Keep your accountability structures in place. Oh, I've lost that screen now. I've lost all my screens. It's back. I must have said something. Keep your accountability structures in place. Your DD council, your provider associations, your consumer groups, your human rights committees. All of that is needed to keep that system properly directed and accountable. The fears that I had coming into Arizona from Utah were all legitimate and appropriate. And in the hands of not properly motivated people, it could be perverted. So keep those structures in place. They're essential to keeping it in the direction that you want it to go. The administering agency does have to have its necessary resources and personnel in place to do it. You cannot take a managed long-term services supports and dump it on a division, like your division of developmental disabilities. They have to have additional personnel. They have to have some expertise they don't otherwise have. To do so would be terribly unfair and create problems downstream for you. Involve your key stakeholders. In fact, 1115 waivers and dual eligible demonstrations are requiring stakeholder involvement. The benefit packages in your services have to be person-centered. You have to insist they be person-centered. They have to include the full range of services that are found in your HCBS waivers, including self-direction. You need to incorporate the ADA and homestead integration requirements for home-based services and community-based services. You have to make sure that the state administering agency, if that's what you go with, has provider network development as a core expectation. I personally wouldn't carve out institutional services, and I noticed that the President's Committee recommended against it either. That really does artificially sustain the Medicaid institutional bias by bifurcating the system. It also removes the most costly service alternative from the cost equation, and it may violate the spirit of Olmsted to do that. This one, if I had to redo these slides, I'd put a black box around this one and stars and maybe a cartoon. This is probably the most important one and the one I'd put at the top of the list if you had a to-do list of things we want to accomplish. Long after we're gone, families, consumers will be left with a system at whose mercy they will be receiving services. And the only way they will have any kind of a guarantee of the integrity of that system for their individual services is a robust grievance and appeal system. That is so critical. I saw over the 10 years that system evolve from an entity that was, quite frankly, a rubber stamp for the system doing what it wanted to a vibrant, consumer-centered system that tried to lean on the side of the consumer whenever it was possible. Without that, consumers really don't have any way to deal with the system and don't have any tools to deal with the system. You need to learn about the medical home health model of healthcare. I think it has significant possibilities for folks with developmental disabilities who have serious medical issues. I think Chris is going to be talking more about this later today. Stakeholders should be involved early and often in the push for uniform assessment of individual needs by the MCO. The managed care entities, the accesses, are pushing very much towards a quantitative prediction of people's need for services based on an assessment tool. And unfortunately, or maybe not so unfortunately, it's coming a lot out of the senior citizens, the elderly programs, and those tools are driving important decision-making in terms of what's going to happen at the home level. How many days a week do you need a housekeeper? How much help do you need getting into and out of the shower? How much meal preparation assistance do you need? Consumers, family members, and others who care about people with developmental disabilities need to be involved in those assessment development projects. My bias is that the administering or the overseeing agency for managed long-term services and supports in a state should be the administrative entity or maybe a quasi-government entity, maybe even a private sector partnership with the public entity. I'm very interested to see how the local control model works with Wisconsin and Michigan, but I have seen the benefits having it centralized at the state level with a state agency, and I'm a fan of it. The system should use or continue to use the National Association of State DD Directors core indicators. Washington has been involved in that since 1999, and we use it extensively to set goals for our system in Arizona, and I'm sure you do here, but it is a good benchmark system to have in place. Rate-setting strategies have to incentivize early intervention of services and home-based services. The system should pay for what it wants. If you want supported employment, those rates should be attractive enough to bring providers to the table. If you want early intervention, it needs to be such that providers will come to the early intervention table. And finally, and I'm sure everybody will say this, ensure that there are transition plans that ease the move into the new system, including preserving the continuity of care, both on the acute care side and the long-term care side. We don't want people falling between the cracks and crashing and burning just because systems are changing. These are the resources I've assembled to stay up to date on managed long-term service and supports. I commend them all to you. They're all worthy. There's a lot of people writing and researching in this area these days, so the information is fresh and it's current and it's up to date. And finally, if you're ever in Arizona, and particularly southern Arizona, and you are a mountain biker, give me a call and I'll take you out to the desert and show you some of our wonderful biking trails, and maybe we'll even see a sunset or two. I think we're waiting for this afternoon to do questions.
Take some questions now for a few minutes, if you like.
Sure. A few minutes.
Panel is, after if you've heard from every state, we'll do a panel so you can ask more questions.
So maybe one or two questions. Yes, ma'am.
In the same reports that you referenced, Washington is number one in competitive supported employment, and Arizona is way down the list. So what are you doing to change that, since that has been a national DDDDSDS agenda and the president's agenda?
That's one of the few areas of disappointment I personally have in my career. One of your advantages, you had Linda. We have been on the bottom of supported employment for more than a decade. And, well, whatever. Washington and Oregon have been our benchmarks, and in fact, we set goals. I set goals with our district offices that the percentage that Washington and Oregon were at was the percentage we wanted to get to. In 2005, I personally sat in the rooms while the rate setters were talking about all the different rates that we had and asked for the highest possible rates they could give me on supported employment. I was successful with that. We got some really whiz-bang rates for supported employment, competitive employment, how to get people into jobs. I left. The recession hit, and those rates have all been rolled back to what they were 10 years ago. So Arizona continues to bring up the rear on that, and it is one of my big disappointments. If I thought about it, I would have tried to recruit Linda Roth before she took your job and had her come to Arizona.
Well, I mean, it would be a cost savings, because I was pulling data the other day, and 39% of our people working in supported employment have benefits. So it saves the Medicaid and other systems to have people having their health care paid for by regular business.
Yeah, and what particularly concerned us is those kids coming out of school. We were watching them. They were falling off the cliff. They were going into workshops. They were going into day programs. And it's because we didn't have the stuff ready to catch them as they graduated, to transition them out of their school programs. That was good for you. We are a fan of what Washington has been doing for some time. Sue?
Can explain how Arizona's different than what maybe some other states are doing, because it's the state agency that holds the risk, right?
That's correct. The Division of Developmental Disabilities, which would be the same as your division here, with our Department of Economic Security, which would be the same as your Department of Social and Rehabilitative Services, together we share that risk. And if we make money, and we did, I think my first couple of years we made money. We reinvested that in computer systems and additional case management. We lost money during the 2005-2006 period. And the department, between us and the department, we figured out how to deal with that shortfall or that profit. And I felt good about that. The thought of having a private sector entity for-profit, in particular, taking that earnings and not reinvesting in the system, I just had problems with that myself. I'm a fan of, and I don't have a bias against for-profit providers, but in this case, that for-profit that just didn't seem to be the right thing to give away.
Rick, maybe two more questions, one from Senator Klein and one from David Lord over here.
Sure.
Oh, thanks. The $3,500 per person cap that exists now, that obviously applies not only to those who remain in institutions, and I'm going to guess that Arizona has still an institutional program. One, okay. What effect does that have, or does it have an effect on migration from institutions to community care? Is there a downward pressure to manage the funds, to save money, that creates a greater market for the community?
That's not only an effect of the system, that is the way the system is designed. The system is designed to keep people out of institutional settings at all costs. And in my 10 years, I can only think of two people who were admitted to either the state hospital or or our one last training center in Coolidge, which is an ICFMR. And that was, the system was built with that in mind, is that we are not going to pay for very expensive institutional services when we can provide comparable supports. And we handle people just as tough as in any institution in the country in community settings. So that issue is long gone in Arizona. We don't debate that. The people at our last facility, our last ICFMR, there hasn't been an admission there in, maybe 1 or 2 in 20 years. And it's slowly going away. And that's by the plan.
One last question.
Do you know if the other states using managed care also include that provision?
You'll have to ask the Wisconsin and the Michigan folks. I would bet Vermont does. They basically have no institution.
And when I talk, I'll elaborate on that.
Yes, and I just had a quick question about you mentioned that a robust complaint and grievance process is really important. And then you went on to say that it started out not so good, and then you saw it get better, got transformed. Could you just elaborate on what happened, what those things are that you think make a robust complaint?
The requirement to have a grievance and appeal system is I think probably parcel of what CMS expects as part of its contract with Access. And when I got there in 2000, I was not pleased. I was not proud of what was getting turned over in the way of decisions on behalf of families and consumers. And the numbers seem to suggest that we were biased towards providers, we were biased towards ourselves, our own system, and that rules were not being interpreted in a consumer-friendly kind of way. The system has to have rules, and those rules have to be enforced, and I don't have any problems with that. It's a matter of you can have a system that says, let's take the edges and the marginal gray area and let the consumer have that because it might make a difference on their well-being, on the outcomes for that individual, as opposed to everything in the gray area goes to the provider or goes to the state. And that's just a matter of setting different expectations for the people who are doing the grievance reviewing. All right, thank you.
Let's thank Rick.